Hello and welcome to Raider HQ After Dark. I am your host Raider, and in this video we are going to be talking about mental health, how it is rated. Actually, specifically what we'll be talking about is a general overview of mental health, how the VA reviews what you claim, the unique discharge circumstances for mental health, and how it is rated if you are discharged for mental health. 38 CFR granting requirements for mental health, review of the DBQ for mental health, review of how it is rated in VBMSR. I will also be speaking about congenital defects associated with personality disorders, as well as the conditional granting of psychosis within a certain period of time of discharge. And finally, I will be speaking to tips and for how to get the manual override. And if you don't know what I'm talking about, I will discuss it, but it's how essentially to ask the rater to if the computer spits out 70%, how to ask the rater to kick you up to the next higher level. Now, what I will not be discussing during this video are the specifics to eating disorders, which are also a mental health condition that can be separately evaluated. And I will not be discussing PTSD at this time, simply because it has its own set of laws, rules, and regulations that will keep me here for 4 hours. So let's begin as I put down my Bob Ross whiteboard here, and I'll share my screen. So the first thing I kind of wanted to touch on whenever I talk about mental health and kind of how it is rated is I want to talk about how the VSR and rater kind of interpret what you claim and how you claim it. So all manual references that I kind of pull up here, because I've got quite a few, they will be in the video description. So this is 53131A. Sympathetic reading and the scope of mental health disorders. So, a claim for a particular mental health disorder should be read as a claim for any mental health disorder. So, this specifically applies to newly claimed conditions. Okay, so we call it on the inside as a claim for one is a claim for all. Now, this is only if you've never claimed something before. If you have been denied for, say, anxiety and you claim depression, a claim for one is not a claim for all in that situation. So we wouldn't send you an AMA letter saying, "Hey, look, you were previously denied for anxiety." So when you're first claiming something on a 526EZ or as a newly claimed condition, you don't have to specifically know what you're claiming. You can just, go with the initial lay symptom that is associated with what you're experiencing. So, like depression, anxiety, irritability, that's all fine. Okay. Now, when we review it, we will, the description of the claimed issue, the symptoms that the claimant describes, we will take all these and we will kind of do our duty to assist to, just throw out there, anything that the examiner gives you and diagnoses you with will count on the kind of on the initial claim, because you're not expected to know the diagnostic criteria for how mental health is evaluated. So it would behoove you when you file a claim for a mental health condition to just literally write out what symptoms you have. Now, you can do that on the claim form itself, and I understand there's only so many characters on it, but do your best, because you want to kind of throw a wide net, as they say, because the VSR and the rater are going to do a sympathetic reading, of kind of what you say. And we're going to, just kind of get it before the examiner, because you are a subject matter expert on symptoms like depression and anxiety. So, anyway, that's the first part of that. Moving on. So, we're going to here's more about guidance for 53131B. And this is talking about when we're reviewing a claim for service connection based upon a mental health disorder. we are not supposed to limit consideration only to the particular mental health disorder, diagnosis, or theory of service connection that you make as the claimant. So, what do I mean by that? I mean, if you tell me, hey, look, I would like to claim depression directly, okay? I was depressed in service. Well, let's say that your service treatment records don't show any depression, but maybe the examiner kind of makes an inference about it could be caused by, somatic symptom disorder where your physical pain is causing you mental symptoms, or let's say it's due to another cause. What this is telling the staff members is not to limit our review to only what you state as the lay person. We're also supposed to expand our view of mental health in all directions as humanly possible. And what it tells us, do sympathetically read the claim as including any chronic acquired mental health disorder consistent with the analysis above. Okay. Now, this right here is going to be something I reference later on in the video, but this terminology, chronically acquired mental health disorder, I would like to say that that is making a distinction between a congenital disorder and a non-congenital disorder. Okay. And basically, were you born with it or did you acquire it? Okay. So this is the first hint to acquired mental health disorders being service connectable. Okay. So I'm going to move on. This is hard to digest, and I get that. So I might have to do a couple videos on it. So moving on. This is 53131G, handling a veteran's discharge from service for a mental health disorder due to a traumatic stress. Okay, so this one right here, this talks about kind of, it says that due to a traumatic stress, but what it kind of means is, were you discharged on your DD 214 due to mental health? If you were, then, and this has to be recent, it can't be like, you were discharged in the 70s, but if you were relatively recently discharged within the last year, and we can go back to the date of discharge as your effective date, then what this means is that we can assign a 50% evaluation because we consider you unstabilized, like your condition hasn't stabilized yet, because you were discharged due to mental health. So what happens in this set of circumstances is we would assign a provisional 50%, and then we would do a routine future exam for you within 6 months to see kind of maybe what your mental health looks like, as it has hopefully stabilized from after being discharged from service. So this could be an increase, it could be a decrease, but it is just one of those things. Now, normally what you hear is you can't get a routine future exam for mental health. Well, this is one of the conditions to where you have to. So now, how you would know if you qualified for this, number one, your DD 214 says that you were discharged for, PTSD, for some kind of mental health, depression. It'll sometimes just say mental health. And then we assigned you a 50%. And on your rating decision, it should talk about the need to schedule, like we will have a future examination as needed. It won't say 6 months on it, but it will tell you that, a future exam is warranted and needed. So, and then it just talks about how we, look for this and how we kind of review it as a staff member. But this is kind of just an outlier that I wanted to talk about and just bring up in this, the overall mental health, conversation. And then moving on from there, I want to talk about how mental health is rated in the 38 CFR. And I do apologize. You guys wanted mental health, but it is a complex topic that requires a lot of, moving parts. So this is the 38 CFR Part 4 under 4.130 right here. And this will be in all the manual references, and all the hyperlinks will be in the video description. So these are all of the criteria that is required in order to be 100%, 70%, 50%, 30%, 10%, and 0%. And basically how we can acquire this information is we can acquire some of it from your treatment records or from your service treatment records if you're very recently discharged from the military. But for the most part, the DBQ that is done by the VA examiner, or in the case of a private medical opinion or private DBQ, that will be done by the private provider. Mental health conditions other than PTSD for fear base can all be done on, well, they can all be done by a private provider. I think they've locked the PTSD DBQ to where only VA providers can do it. I mean, the last time I checked, they didn't have a front facing PTSD one. So that's why I wanted to cover that in a different video. But when we're reviewing this, okay, the thing that I wanted to point out in how mental health is rated is the computer decides. Okay, so I can't tell you, like, if you were to tell me, hey, look, I've got these symptoms right here, will I be 50%? I can't eyeball it and tell you because the weight of the symptoms that are presented in each category weigh differently. So panic attacks doesn't necessarily weigh the same as, say, chronic sleep impairment. Okay, they have the computer itself assigns a value to each one of these symptoms. So if you have a combination of them, different combinations within the same kind of level or tier, and maybe a few from the next higher tier, I can't eyeball it and tell you. But for the most part, what we're looking for that has the most weight, I guess, is probably what you want to know, is the occupational and social impairment category that the examiner assigns, and also, to some degree, the individual symptoms. Now, what can happen is if you can have a combination of, like, let's say this social impairment level right here, inability to perform tasks. So if you had this one and you had some symptoms from this particular, from the 50%, you could be kicked up to the 50% if you meet the unspoken threshold. And I know I'm not doing this much justice, but the reason why, and I'll just show it to you in the evaluation builder, is when we do our mental health review, right? This is the evaluation builder. This is the mock system that we use to actually, you know, transcribe the DBQ's information into VBMS so the computer can calculate it. All right. We don't get, it's not very black and white. It's just you just shove in the numbers and then you get what you get. Okay. So I just want to use this as an example of I did not pick the total occupational social impairment, but I did check the symptoms. And then if I come down here, it gives me 100% as the option, as the suggested value. Okay. Now, if you were to go and look at this, it says that total occupational impairment is required in order to be 100%. Well, that's not true. If you have enough symptoms, you can have a lower threshold for the occupational impairment and still, and if you have a couple of these, you can still meet the 100% requirement. And the reason for that is that they did, and I don't have it in front of me, but they did kind of an update to say that the social and occupational impairment should not be the total consideration for whether or not you're at the 100% level. So just kind of keep that in mind. Now, what I want to review for here is the way the current situation, or the way the current VASARD is for mental health. What happens is the 100% is pretty much locked under what we would consider personality disorder symptoms. So you need a lot of the lower symptoms, but in order to get to the 100%, which I know that most people are, you would have to have at least one, maybe two of these symptoms. So, gross impairment of thought process. This is not something that's typically associated with a mood disorder, okay? Or communication, persistent delusions or hallucinations. I mean, we're thinking still personality disorder. Grossly inappropriate behaviors. That technically could be, with a PTSD or maybe a mood disorder like, mania for bipolar or borderline. Persistent danger of hurting yourself or others, that's not necessarily locked within a personality disorder, but the lion's share of them are intermittent inability to perform activities for daily living. I have seen PTSD under that category, but the barrier for examiners for that is typically you have an inability to do it. And when I just want to take a second for that. When reviewing for that, like whether or not there is an inability, is there a functional limitation of the way that your brain is wired to limit you from doing that? Or if you have it due to PTSD, is it possible through talk therapy and medication to make the circumstance better? Is kind of sometimes the way that that is viewed. Then you have disorientation of time or place. This one can be due to panic attacks, actually. Panic attacks can be, if medically indicated, caused can cause this. They can cause disorientation of time and place. Now, this memory loss is complete. Like, think of dementia, this is almost a complete memory loss. It's not like I forget my keys somewhere, and I'm not belittling it in any way, shape, or form, but this is meant to be significant mental memory loss due to like TBI or, some other kind of like really profound cause. All right. And then occupational and social impairment for the 70%. It hates my guts. So for this one, why does it do that? We're looking like this is 70% is typically where most people with mood disorders, non-personality disorders, this is typically the top of their pyramid because it is hard to kind of square peg round hole a lot of these personality disorder symptoms into a non-personality disorder condition. So what happens is a lot of the VA community gets locked in at 70%. And some of the symptoms here, occupational and social impairment with deficiencies in most areas, that's the occupational side that the examiner will fill out. But when we come down here to the symptoms, suicidal ideation, there's, judgment, thinking, and mood issues. There's obsessive rituals. There are a couple of personality disorder traits in here, like the intermittent, illogical, obscure, irrelevant speech patterns. Those are more typically associated with, personality disorders. So you have some sprinkled in here at the 70%, but you don't need everything in a particular category or a tier. You don't need to have everything in order to be granted. So near continuous panic attacks, that one weighs heavily. Same with the near continuous depression. So if you have that symptom, it will basically take you up to 70 pretty easily as long as you have a few of the others below it. And I'm just going to be rambling about symptoms, guys. This video is long and it's a beast, so bear with me. Spatial distortions, that one can also contribute to the 100%. Neglect of personal appearance and hygiene. That's quite common, actually. Difficult in adapting to stressful circumstances and situations. The spatial distortions and neglect of personal hygiene weigh some of the highest. They have very, very heavy weight to them when the computer factors into it. I do know that. the inability to establish and maintain effective relationships also has a higher, not as high as the other two, but it does have a higher importance. And then when we go down here to the 50%, we're looking at reduced reliability and productivity as the occupational um, standard. And then we're going to start out with flattened affect. That's kind of like how you carry your face. Like you'll just have no expression on your face. That's kind of what a flattened affect is. You don't change, your facial appearance doesn't change very much because your mood doesn't change very much. Circumstantial circum okay. Stereotype speech, these are also personality disorder type symptoms. Panic attacks with a specific frequency, that's, um, that's kind of this one weighs heavily too for the 50%. All the personality disorder ones weigh heavily also. Understanding complex commands, that can be part of like a severe anxiety condition, but for the most part, it's associated with personality disorders. Impairment of short and long term memory. This is quite common. You see this quite often in mood disorders. Same with impaired judgment. Um, Impaired abstract thinking. This is mostly personality disorder territory. It can be with anxiety disorders um, that have some delusions, fixed delusions or delusions. Disturbances of motivation and mood is quite common in mood disorders. Difficulty in establishing and maintaining effective relationships. And then we have the 30%, which is occupational and social impairment with occasional decreases in work efficiency and intermittent periods of inability to perform occupational tasks. I'm going to just go out on a limb here and say that the occupational assessment is completely subjective. So it's, you should talk about it in your exams, but it just comes, there's no testing for that. Like there's no way for the examiner to test with it. So it's going to be based upon the subjective information that you give the examiner. So tell the truth, but keep in mind if you just lowball it, it will drag your percentage down if you lowball it. So never lowball symptoms when going to the examiner. So for this one, these are just you know uh, depressed mood, anxiety. This is all mood disorder stuff, chronic sleep impairment, forgetting names. You don't need all of these to get it, but 30% is actually very easy to get. I mean, if you have the most basic of symptoms for mental health, you should be able to secure a 30% rating. And then this one, the 10% is the occupational and social impairment due to mild or transient symptoms. So, I mean, you shouldn't almost have a diagnosis at this level. Like, you barely, what you would see is oftentimes adjustment disorder here. And you're saying, I'm fine. So, if you have a diagnosis of adjustment disorder and you say you're fine, then you should be 10%. And then 0% is just a diagnosis and you didn't go to the exam almost. I mean, that would be kind of, uh, you know, it has been formally diagnosed, but I would consider the symptoms not severe enough to, count for anything, or medication completely controls it, is almost what the 10% should be. So, anyway, eating disorders will be on another video, but let me go ahead and show you the DBQ for mental health. So, this is the spot where we're going to, where the examiner will talk about the diagnosis, okay? And this is an interesting conversation because the diagnosis you get doesn't matter. It honestly only matters for, whether or not it's congenital or not, but it doesn't affect your rating at all. Like, you don't become 100% because you have a different diagnosis than, say, another veteran. It The way that you are rated is explicitly and exclusively due to the symptoms that you manifest during the examination and somewhat in your treatment records. Now, one of the most important things here, besides having, a mental health diagnosis, is um, this question: Does do you have more than one mental health diagnosis? There are times whenever you can have a mental health diagnosis that is service connected and a mental health diagnosis that is not service connected. You can think of maybe a character of Discharge review. I just did a video on that earlier today, where the disability in question is was acquired during a non qualifying period of service, and that particular diagnosis can't be applied to your condition. So what can happen is if you have one diagnosis that's good, right, that can be applied, and one that is not, maybe during a period of time that is not qualified, what can happen is they will ask about delineation. So it's 2D. Is it possible to differentiate what symptoms are, well, they should have a question for this that's in general. Did I skip it? Yeah, here it goes. Is it possible to differentiate what symptoms is or are attributed to each diagnosis? Okay. So if you had one good diagnosis and one bad diagnosis, the worst thing that can happen here is they say yes. And then they say something like, and it won't let me type, but let's say you had depression and PTSD, but PTSD could not be considered because it's part of a bad period of service. What would happen is if they said yes, then they would divvy up the mental health between the two. And everything that gets assigned to the disability that can't be service connected because it's part of a bad period of service, you don't get access to those. Those don't get to get counted towards your disability rating. So that's kind of bad. The better version is, let's say we have the exact same scenario, but they say no. Well, when they can't differentiate between what causes what, the tie goes to the veteran, and you get to claim all the mental health and keep all the mental health for the good mental health condition that's getting granted. So it is always better, and I'm speaking to the people doing the private DBQs, okay? If possible, and if your examiner believes so, it is always better that they can't differentiate between the conditions, right? Because if they can, there are times whenever it can take away from your rating decision. So this is a little tip or trick, or this is a very important question. 2B is very important. And then we scroll down here. Now, whenever I was looking back here at all the occupational criteria, which is the first of each one of these tiers has an occupational risk factor or assessment. This is where it's written. So question 3A is where they will weigh in and give you an answer to this. So I will say that the occupational and social impairment, the higher it is, the higher it will drag your rating decision. So if you had, occupational or social impairment with deficiencies in most areas to include everywhere, then but you didn't have all these symptoms. Maybe you just had some of these symptoms. Well, then it would drag you up higher. You can do more with less, I guess. So this is an important question. And then when we scroll down here, the only other consideration that I have is this. Okay, as a rater, if your claim was in front of me, I read through the history. Okay, I read through every single one of these evidence parts where the examiner will put stuff in. And what I'm looking for is I am looking for things that don't make sense, that are incongruent with each other. So if your and this is especially for private DBQs, like whenever I'm reviewing a private DBQ, if they say that you can't communicate, where is that one? Okay, speech, intermittent, illogical, circumstantial. It'll say like gross impairment of thought and communication. Like if you had all of these checked, right? And I'm looking for, where's the one for communication? Inability to understand complex commands. Okay, let's just say that some of these were checked, right? just discussing communication, and I had this happen. This is why I'm bringing it up, is because I had a person who could functionally do their job as a speech therapist, right? But the person said the examiner said that the person was able to do their job, but then turned around and said that they cannot communicate effectively in any direction or any way, shape, or form. That's irreconcilable, conflicting evidence. Like, these two are mutually exclusive. They cannot be true at the same time, right? One of them has to be true and one of them has to be false. So I had to send, the private DBQ back to the examiner and ask them what is going on with it. And what actually happened is that the private examiner said, "Oh, well, the veteran's actually from, this other country, and I can't understand their accent. So I couldn't, like, their speech pattern was so, how they spoke and what they said was, the problem." And I said, "Okay, sir and or ma'am, you can't do that. That's not what we're talking about here. When you check these boxes, it has to be due to the mental health condition. The fact that they are of another ethnicity to you is not a mental health disorder, okay? It is just a communication issue that you're having. You have to exclude that." So that's just kind of like one of the circumstances with the private DBQs that I wanted to bring up, is that the rater will be searching all of these things, looking for things that are not dress right dress. If you come in and you say that, if they check the box that you cannot maintain your personal appearance, but your personal appearance is immaculate, then I'm going to question that. Was this just a one-off? Like, what happened? Is their presentation the norm? How did you identify that their presentation was normally, they're unable to groom themselves? How did you come to that conclusion? What evidence did you use? So, because I have to be able to point and justify why, the worst of the two reports, either you can groom yourself or you can't, which one is true? I've got to be able to point to the evidence that more probatively aligns with that. So, and I know we're getting up there. It's 32 minutes already. Oh my gosh. Okay. So, this is down here. These are the way we plug and play. So, the examiner will go through in your examination and they will actually, do an interview with you. And based upon their clinical assessment, they will report what the symptoms are. Okay. So, these matter. This is going to be plug and play. Now, the tip for the manual upgrade, and what am I talking about with that? Okay, so I'm going to go back down here to the evaluation builder. This is me plugging into the VBMS system all your symptoms. Well, the way that this works is it spits out based upon what we put in there, it will weigh all the evidence and it will assign a suggested evaluation based upon the inputs. And then I can either check the box and agree with that, at which point in time it will blow in all of this information to your rating narrative, or I can disagree and do what is known as a manual override evaluation. Now, because this one I did was a 100%, I can't go any higher than that. But let's say that I did it and it came out to 70. I would have the ability to manually upgrade it to 100% or manually downgrade it based upon additional medical evidence. Okay. Now, there is no definition for additional medical evidence. It is subjective to the rater. Okay. Now, the disposition of the rater is going to be that they don't like doing this unless they can point to something that gives them good justification. But you can ask them to do this. You can fill out what is known as like a VA form 21-4138, a statement in support of claim. And you can, on there, you can ask the rater, "Hey, please consider this ancillary evidence that I have submitted with my claim, and if you believe so, could you please manually upgrade me, manually override me to the next higher level?" So for those of you that are 70% that want to roll the dice, that you feel like, you've got enough evidence, You can do that. You can ask for that. Now, what evidence do I personally, if your claim was sitting in front of me, what evidence highlights to me, right? Is if I had your claim, the evidence that I find probative, hospitalizations, not necessarily due to ideations of SI. Um, it doesn't have to be for anything specific. You could have RRTP, for rehabilitative hospitalizations. You could have mental health, like inpatient hospitalizations. You could have legal issues due to your mental health condition that says, maybe you know, during a specific episode, you acted out and you got arrested. Like things like that, things that I can point to that show me that your condition is worse than the boundaries that we give it, than these criteria right here. But you have to be able to point to it. I would even potentially take like a divorce, as a under consideration and just say, hey, look, I can't like these, but explain it, explain why your condition influenced the outcome of your marriage. These are the things. It's not going to be about medications you take, okay? It's not going to be about that because I can't quantify that. But I can quantify how damaging a hospitalization, an arrest, or a divorce is. I had to lose my job because I was hospitalized for 2 months. Like that matters to me. Like that's meaningful to me. Now, is this a guarantee that the rater will upgrade you to the next higher level? No, it is not. But it's at least a shot. If you're going to do an increase, you can ask them. This is the only time, mental health is the only time that we have this ability to override the findings of the VBMS system. And the reason why we have that option is because we don't get a say in the weight of these particular symptoms, right? So we can use ancillary evidence to say, okay, I get the fact that VBMS weighed it this way, but as a human being, I'm going to weigh it differently because I see the evidence of X, Y, and Z, So I would, if you're ever going to do a mental health increase, let's say if you're 30%, you want to go to 50, ask for them to kick you up to the next higher level, to do a manual override of the evaluation you're given if you have supportive evidence to show that you, the veteran specifically in your life, have, extenuating circumstances that are not found in the 38 CFR. Oh gosh, we're at 37 minutes. Okay. So the last thing I wanted to kind of talk about is congenital defects. Okay. And congenital defects, this is a gray area. And some of you have been the victim of this, some of you have not. And what I want to say is the term personality disorder and mental deficiency are not considered diseases or injuries that can be service connected on their face. There are exceptions. But the problem is the VA doesn't define what a personality disorder is, nor does it define what a mental deficiency is. Okay? So we have these conflicting regulations in the system that say, hey, under 38 CFR 4.9, a personality disorder is deemed a congenital defect and we can't grant it. Well, let me go back here to this and say that they kind of, this is how they've flavored the training, at least for the VSRs and raters, to say that in order for a condition to not be a personality disorder, it has to be an acquired mental health condition, right? You have to have gotten it somehow. Like, in PTSD, you had a stressful event which gave you the PTSD. If you didn't have the stressful event, then you never would get the PTSD. Is kind of the way that the VA, for VA purposes, internalizes, how you acquire a mental health condition, because service had to give it to you, right? Or aggravate it in some way. So coming back here, and I'm going to, oh, there we go. Okay, so these are not diseases for VA purposes. However, there are caveats to it. Okay, however, disabling resulting from a mental health disorder that is superimposed upon an intellectual disability. So this right here, 38 CFR 4.127 says, hey, look, you could have had a personality disorder and it can be secondary. So you can have like symptoms that are secondary to the personality disorder that kind of manifested due to certain circumstances. So essentially what this is loosening up the fact that a personality disorder is a bar to being service connected. So there are certain circumstances in which it can be a condition. And that's where we get to 522E1C. And I'm sorry, I'm kind of rushing, but I'm looking at the time. Establishing service connected connection for a congenital defect or hereditary disorder. So, in order to get a personality disorder, and when I think of personality disorders, I think of schizophrenia. I think of, and this is just me personally, I think of borderline personality disorder and bipolar disorder. And the reason why I think that is because it is hard to acquire those conditions. The mental health community thinks that individuals are predisposed for those. So if you're predisposed for them, you don't necessarily acquire them through the military. But I leave it up to, if you had a qualifying personality disorder, you could still get it service connected. So even if let's use schizophrenia, because I think we can all agree that that's a personality disorder, generally accepted, that if it first manifests in service, right? So you didn't have it beforehand, you just were like at the qualifying age and it just popped off in service. You started to have, behavioral outbursts. They can trace your personality disorder to first manifesting in service, but not before service. It can be granted. So, and then we can have the pre-existing aggravation of, yes, you were treated for it before service, but in service, maybe stressors, war theater, combat theater type situations caused the condition to manifest and progress at a higher than normal, like the disease process went further, it was exacerbated. So because it military clearly made it worse, they will go ahead and they will, consider their contribution to the condition, the aggravation itself, as service connected. And I'll talk more about pre-existing conditions in the aggravation video that I do. But moving on. So, just because it's not complicated enough, okay, for personality disorders, you also have it to where under 3.309A, you can have symptoms and conditions of psychosis that can be granted within a certain, like if they manifest after discharge within a certain period of time. These particular personality disorder traits can get service connected also. And just for those that want to know, these are the definitions of psychosis that can be granted under the condition. So, personality disorders, if diagnosed within a year from the release of discharge, can also, ones that manifest to this degree. So, brief psychotic disorder, delusional disorder, other schizophrenia, schizotypal, or not often spoken about, but medically induced psychosis. So these are oftentimes, certain individuals can have allergic reactions to medications. Certain individuals can, it can be a side effect of a certain medication. These circumstances, if chronic in nature, right? Like you have to take the medication for the rest of your life, but it causes you to have delusions or hallucinations, then you can get these medically induced disorders service connected. So, and this is kind of the general overview for mental health that I wanted to do. First take on it. And sorry it's so long, but it's such a complex topic that I have to chunk it up. And, PTSD will be discussed at a later time. Stressors will probably need multiple videos on, because I'll need one for combat, non-combat, personal trauma MST. There are a lot of regulations about mental health, and it was kind of the reason why I wanted to hold off on it, because there's so much to it. But this, like I said, is a general overview. Let me know your thoughts in the comments. Let me know if this was an okay video for you. Uh, it's hard because it's a lot to digest. So, anyway, thank you. If you watch to the end, you've got saintly patience, and I appreciate all that you've done. Do all the YouTube things, like, subscribe, share with a friend, all that. And that's all I got for you. Raider out.